I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
54-year-old woman with recurrent metastatic stage 3A left breast cancer. Initially, she was a T1C into a ER 96%, PR0, HER2 negative with a Ki67 of 32%, and oncotype at that time was 41. She was treated initially 2 years ago with nipple-sparing mastectomy and axillary lymph node dissection, which was complicated by necrosis of the nipple. She declined adjuvant chemotherapy despite the very elevated oncotype score, and developed left skin recurrence with metastasis in the axillary lymph nodes and numerous osseous lesions. She was treated with letrozole, palbociclib, and denosumab with complete response on PET-CT 6 months ago. She presents today with focal pain in the right hip found on a PET scan to have high-risk right femoral neck osteolytic lesion without any other sites of metastatic disease. And the question that is posed for consideration is, how should her right hip metastasis be treated? And is there a role for local consolidative therapy in addition to the stabilization? So we have the PET-CT that had an SUV of 6.8 in the right femoral neck lesion. The patient, again, we reviewed her surgery with axillary dissection and the pathology demonstrating invasive ductal carcinoma, ER 96%, PR0, HER2 negative, with a Ki67 of 32%, and the oncotype, again, in the high category at 41. She did not receive any radiation. Her chemotherapy initially was declined, but after she developed metastatic disease, she was treated with palbociclib, single agent, and denosumab. She initially declined adjuvant endocrine therapy, and then did ultimately, I apologize, start on an aromatase inhibitor with letrozole. So her systemic therapy currently consisting of a CDK4/6 inhibitor with palbociclib and letrozole, as well as denosumab. So I will open it up possibly to Dr. Shah. How would you treat her right hip metastasis, and what do you view as the role for local therapy in addition to stabilization?
So in a 54-year-old female, I would imagine is ambulatory with this location. I would call my orthopedic surgeon, orthopedic oncologist. This is a weight-bearing area, and frankly speaking, a high risk of fracture. So I would not proceed with radiation alone. I would imagine my orthopedic oncologist would stabilize, depending on the lesion, the size, and the location. That may be as simple as an intramedullary nail, or require a more extensive surgery depending on kind of the extent of disease. Following either of those procedures, I would typically recommend adjuvant radiation therapy to consolidate basically local control in that area to try to prevent further skeletal events.
Okay, perfect. And Dr. Pegram, I'm guessing you agree with the therapeutic choice for a CDK4/6 inhibitor, aromatase inhibitor, and a bone modifying agent. Any other comments about her systemic therapy?
Well, she was said to have had a clinical CR on that initial regimen until the right hip metastasis. So this, in contrast to the last case, is true RECIST progression, being a new lesion. And I definitely would consult orthopedics and radiation therapy as mentioned. But since this is RECIST progression, we're back to the consideration of assessing the PIK3CA mutational status once again, treating with alpelisib with fulvestrant in the second line if she has a PI3 kinase gene mutation. And if not, then fulvestrant with or without everolimus would be a choice in that case. The combination of fulvestrant plus everolimus has been shown to be active in a randomized phase 3 trial compared to fulvestrant alone in the PreCog 0102 data. So there is precedent in terms of PFS benefit by adding a mTOR inhibitor for PIK3CA wild type progressors following CDK4/6 inhibition in an AI.
Perfect. Thank you so much. So we would recommend, in summary, orthopedic consultation, radiation therapy, and then systemic therapy considerations with assessment of PIK3CA status, and make sure the patient has genetic testing to look for targeted therapeutic options, and then consideration of therapy per Dr. Pegram's recommendation.